All right, thank you very much for having me. So I'd like to talk about some work we did in March and April to deal with the acute shortage of ventilators in our hospital system here in New York City. Regarding disclosures, I receive funding from the NIH, and unrelated to this talk, I do receive funding, I've received speaking fees from a ventilator company, and I've done consulting work for another company that's not a ventilator company. I don't have their ventilators in my hospital and I don't use them in any of my work. I wanted to talk briefly about our experience here in New York, just to give a little bit of background, because I think the context is very important for what we did. And then talk about our acute ventilator shortage and what I think collectively we as a profession can do to try to avoid the scenario playing out elsewhere. So if you'll bear with me here, I'm actually going to start by reading a poem that I wrote a month and a half ago when this was all going on for context. I've never seen war, but I imagine it much like New York today, a perpetual plunge into panic, hyperarousal, and dismay. Streets are empty, stores are shuttered, subways desolate, Broadway's dark, field hospitals best the spring bloom for the eye's attention in city parks. We care for critical colleagues unconscious and near death, who may forebode our shared fate in their last agonal breaths. We face the fragility of our flesh, not together but alone, for families will never meet and stories never told. Hundreds die here every day, too many for the morgues, so bodies pile in refrigerated trucks outside the wards. Patients die abruptly and alone because they must, to stop spread of the contagion as our protective gear exhausts. We do our best with what we have, but our best thereof does not change the fact that we alone are not enough. Help's not coming in force, so is this the end of our arc? Or can our best be enough for you, New York? So from a data standpoint, this happened very quickly, and I think it's important to recognize that what was playing out in the newspapers and the news media was actually, in this case, a very accurate reflection. It was not sensationalized. If anything, they didn't have a full grasp of just how dire things potentially were behind hospital walls because media wasn't allowed into the hospitals. As an example, so the first case identified in all of New York State was on March 1st. We started seeing an uptick in our hospitals in the third week of March. And you can see, we started, in, I guess it was March 15th or so, 17th I think that is, with 28 patients across our hospital system who were in the ICU for COVID. And within a span of 10 or 12 days, we were up to over 300 patients in our ICUs. And if you look at the bottom graph here, you can see almost every single one of those patients that was in an ICU was on a ventilator. So our hospital network, the New York-Presbyterian Hospital system, has 2,600 inpatient beds and normally about 350 ICU beds across 9 hospitals with acute inpatient care facilities. So you can see we more than doubled our normal ICU capacity across our hospital system. In terms of the particular hospital that I work at, Columbia's main campus, our normal capacity is about 110 beds. At our peak COVID ICU census, we had over 230 ICU patients, all ventilated, not including the large ICU that we were running out of the emergency department. We were putting patients anywhere we could think of that we could convert space quickly enough. So we had multiple operating rooms with patients in them. Our cardiac cath lab was converted to ICUs. We converted ward beds and step-down beds into ICUs. The Children's Hospital of New York is actually adjacent to ours, and so we started putting adult patients in the Children's Hospital and staffing those ICUs. As you saw in one of the pictures I showed, we converted our soccer field at Columbia University to a field hospital. And as I mentioned, we also covered the ERs. So we were truly exhausting any possible space we could find. In terms of outcomes, they're, I think, relatively consistent with the data that have more complete follow-up. Overall, we have roughly, all across the campuses, somewhere between 20 to 25% mortality rate among discharges. And this is obviously an evolving number with some patients having stretched out hospital courses. And this is across all admissions, not specific to ICU. Our ICU mortality rate is, I think, in the 40 to 50% range, which would be consistent, actually, not just for COVID, but for what you'd expect for severe ARDS. So with that context, I think one of the very unique things that happened that's hard to describe for people who working in other parts of the country is that the standard of care in New York fundamentally shifted. The concept of best practice didn't really exist anymore, and both the hospital system and the state, as you'll see on the next slide, adopt explicitly a crisis standard of care, saying that just do the best you can with what you have in this context. And this was to the point that it was actually issued in an executive order by the New York State governor, where he provided legal immunity from civil liability for anything that happened, as long as it wasn't done in gross negligence. So all of the providers who were trying to do the best with what they had were legally protected from getting sued from it, as long as there wasn't a case of gross negligence. This is a very powerful and perhaps controversial order that came down from the governor's office. So part of how that got translated in our hospital is we actually developed a pyramid staffing model. So I, as an intensivist, was responsible for 4 ICU teams, each that had roughly 15 patients. And so my job was to see 60 patients, all with severe ARDS on a ventilator every day. And that's what all the intensivists in our hospital were doing. And that was in part necessitated by the fact that our ICU docs also cover other campuses. So we were stretched quite thin, doing very unconventional staffing models. And as I think a lot of hospitals experienced, we had a substantial shortage in respiratory therapists as well. Our RT to patient ratio was as bad as 1 to 84. So most of the ventilator management fell directly on the ICU docs, especially because you had non-ICU nurses coming into place, so they couldn't even do simple things because they were new to the ICU environment and unfamiliar with ventilators. So in terms of ventilator shortages, there are a couple different ventilators that people have advocated using, all of which we've done. So obviously the full feature ventilators, which is what we normally use, anesthesia machines, which we started using very early on. The one caveat is they're very big and bulky and they might not fit in a lot of ICU rooms. So the use of anesthesia machines almost has to coincide with converting other larger spaces unless you have a hospital with very large ICU rooms. We also used these portable or transport ventilators, if you will. The ones that we had were the LTV. I'm not endorsing a particular brand, but we got several of these also from the national stockpile. And then lastly, conversion of non-invasive ventilators to invasive support, which is somewhat limited by the power of the ventilator. So, but then what do you do when you've done all of those things and there just aren't enough ventilators left? And that's the scenario that New York City was facing. Both the governor and the mayor were openly talking about an imminent exhaustion of the ventilator supply, with projections coming within a matter of days. And I can tell you our internal numbers were at times even more dire than that. So, there's often this push for medical triage, and New York State is fairly unique in that we actually have State Department of Health explicit guidelines on ventilator allocation that was put in place, I believe, in response to a flu pandemic several years ago. But the state has explicit guidelines on how to triage ventilators, basically relying on SOFA score and certain comorbidities that would mean imminent death. So if you had acute traumatic brain injury, or if you just experienced a cardiac arrest and now you're completely comatose afterwards with multiple signs of unlikely recovery, those would get triaged to not receiving a ventilator. And then otherwise it was really reliant primarily on SOFA score. And this got to the point that hospital systems were working with the State Department of Health to plan to implement these because of the projections of the shortage. And so really what we were faced with is, the other option being death, if we couldn't come up with some way to stretch our existing supply of ventilators. And so I thought it'd be helpful to provide a timeline of how quickly this all evolved, just to get a sense of how rapid things changed in New York and how rapidly they could potentially change somewhere else in the country or in the world. So on March 17th, once our numbers started to uptick, I got a call from my boss, who got a call from the COO of the hospital asking if there was any way to split a ventilator to support multiple patients with a ventilator. And I thought that was crazy, but said I would look into it. And so I spent the next couple of days developing a strategy just with test lungs on the bench and writing a draft protocol. And that's around the time, as I was doing this, that these dire predictions started coming out from the city and the state of an imminent need for ventilator rationing. So by that Friday, I had a prepared protocol, and I called BTT is Boyd Taylor Thompson. He's the former medical director of ARDSNet and of the Pedal Network, and a mentor of mine. Gave him a call, basically in a cry for help. I wanted to make sure that we were doing the right thing, and I wanted his help in putting together a team of experts who could scrutinize what we were planning to do and scrutinize our protocol and make sure that it was as best as it's going to get. So he helped arrange a panel of respiratory therapists and PhDs from across the country to help review our protocol. So in the span of 5 days, then we were testing the protocol on an anesthesia machine in test slugs, and that's Sunday. So 5 days later, we actually had a dress rehearsal with the hospital leadership in the operating room, with the heads of NYP and representatives from all of our hospital campuses coming to basically see what we thought we might be able to do. That following Monday, the 23rd, we got approval from the New York State Governor's Office directly, and from our hospital ethics group, and we opened the operating room as an ICU for the first time. Then the next day, less than a week after, or 1 week exactly after we got the phone call, we actually started doing this. The following day, the protocol, in response to some media inquiries, ended up getting publicly disseminated via the Greater New York Hospital Association, which is our local hospital consortium. The following day, multiple professional societies condemned our practice. And I just want to share a little bit of language from their joint statement. So you can see the societies listed at the top there. And they say that they, quote, advise clinicians that sharing mechanical ventilators should not be attempted because it cannot be done safely with current equipment. In accordance with the exceedingly difficult but not uncommon triage decisions often made in medical crises, it is better to purpose the ventilator to the patient most likely to benefit than fail to prevent or even cause the demise of multiple patients. And so while I appreciate their caution, this put us in a very difficult spot, because basically they're advocating for us to start triaging ventilators and allowing patients to die, and show me a risk prediction score that does that perfectly. Certainly SOFA does not. So we felt a moral obligation to continue what we were doing, and had multiple levels of input to make sure that that was the right thing. That same day that the society statement came out, the Assistant Secretary of Health and Human Services for the federal government emailed me personally to say that he and the Surgeon General were supportive of our efforts and to thank us for working on them. The next day, we integrated our screening protocol into the electronic health record. By the following week, we felt that we were ready to go. We had done a handful of patients, and by the last pair, which I'll show you the data on shortly, felt that we were ready to scale up if necessary. And so we paused for the ventilator sharing at that point until we ran out of ventilators. Subsequently, Health and Human Services, after that private email that they sent the Assistant Secretary and the Surgeon General, actually publicly released our protocol, essentially describing it as best practice. And so they tackled directly the issue of people considering splitting the ventilators and what the alternatives might be, such as either death or handbagging patients. And this was actually going on in other countries in Europe. So there was a very real sense that this was coming here too, with how quickly things were evolving. And in that HHS statement, they explicitly addressed CDC and FDA guidelines, essentially saying that if you feel this is the right thing to do, it's reasonable to do. They sort of covered liability concerns with it as sort of an off-label use of an existing medical equipment, basically. And like I said, in this statement, actually released our protocol across the country. So starting on April 1st, we converted additional ORs into ICU space to expand capacity and had multiple academic centers around the country reaching out to us saying that they were going to adopt the protocol. And then thankfully the next week our ventilator supply started to improve, and the following week our surge peaked. So with the influx of ventilators from California, Oregon, and the national stockpile, and having social distancing work, we were able to avoid needing to do this on scale, even though we felt we were ready to do so. So that's sort of the timing context. I think it's important to recognize that this was done as a public health initiative. We weren't doing this in a cavalier fashion at all. Before proceeding with this, we had an executive order from the governor of our state explicitly giving us the green light to do it. And we actually, our hospital leadership was talking with his team personally. This was an initiative that wasn't initiated by me, but came from hospital leadership. They felt that something like this would be necessary, and so asked us to work on it. Our hospital ethics committee explicitly approved it, recognizing there are some difficult ethical considerations. And we actually had our IRB take a look at it and concur that what we were about to do was not research. That being said, the ethics committee and us felt that the best way forward would actually be to obtain consent, just like you would for any other ICU procedure, because obviously this is you can think of it in a way as an invasive procedure. It's something that is fairly unique. And so in that consent, we explicitly acknowledged that it was being done to benefit society and wouldn't directly benefit the patient unless we ran out of ventilators. So it was really being done for the public good. And I think one of the very admirable things about this is all the surrogates that we approached consented for it because they recognized how dire things were looking at the time. In terms of why we started doing this, we did it before we fully ran out of ventilators because we thought it was important to gain experience in a controlled setting, both to determine if this was a realistic option and incorporate it with planning, so that we knew what we were doing so we could scale rapidly if we needed to, and to plan the movement of patients and ventilators throughout the city, because if there are certain centers that are able to do this on scale, then you would potentially direct ventilators and patients to those places because they have the capacity to support more ventilators, as opposed to a model where every hospital is doing this on their own, which we thought would not be safe. So this is our protocol. It's available online on the website listed there, protocols.nyp.org. The main point in showing this, or the two main points, are one, to acknowledge all the folks from around the country who had input on this. And then second, to acknowledge A through P here. This is far more than simple plumbing. This wasn't connect a couple of pieces of tubing and put patients on. And I think that is critically important to emphasize, because that's a lot of what was out in the media at the time and in social media. And this is something far more different that thought about patient management and not just plumbing. So in that theme, I really think the greatest danger lies in the simplicity of the configuration. It's so simple to connect a T adapter and put two hoses on the end of it. But that simplicity also is what makes it so dangerous. Safe execution really requires picking the right patients, having the right intensivists do it, and planning ahead of time what you're going to do. So our protocol had some key safety measures I think is worth highlighting. One is the use of pressure control. And the reason for that would be that mechanical changes in one patient would not affect the other, because you have two circuits in parallel According to Ohm's law, the driving pressure would stay the same if something downstream changes in one patient. And we both thought this theoretically, but also then tested it with test lungs as well to confirm that that was the case, that the ventilator would continue to function properly. Also, our protocol mandates paralytics so that one patient doesn't start triggering the ventilator, and to prevent, excuse me, pennant lift between patients. We use, I think uniquely, patient-specific inline monitors and alarms. So while the ventilator, even if you can split the plumbing, you still only have alarms for one patient. And in this case, it would be the two patients in aggregate. So we thought it was important from a safety standpoint to have independent alarms for each patient. We only used medical grade supplies. We built in several safety checks throughout the protocol. We thought about infection control with multiple antimicrobial filters and matching patients that would get paired by pathogen. We used compatibility criteria to make sure patients could be fully supported, and several others that are reported in the protocol. So I wanted to briefly review the compatibility criteria. So part of it is fairly straightforward. The sort of acceptable limits in either patients are ideally what you would see in an ARDS patient in general in terms of tidal volume management and that sort of thing. But we emphasize also between patient differences, prioritizing driving pressure as the thing that we wanted to keep as similar as possible between the two patients, because we knew that would influence patient-specific tidal volume on the shared ventilator. So I think another important thing that we did was rather than just pairing two patients that looked similar, we actually matched them on ventilator settings before pairing them. And so basically the way that worked is we would initiate deep sedation and paralysis, put them on pressure control with identical ventilator settings, and make sure that each patient independently tolerated it on their own ventilator. So then there wasn't a question of whether they would tolerate it once you place them on a shared ventilator, because they're already tolerating those settings. We had specific safety checks built in there. And we also had a safety check built into the shared circuit, which was once the proper ventilator settings were identified, we then used the shared circuit, initiated those same settings with test lungs to confirm that there were no issues with the circuit leak or ventilator alarming or anything like that before transitioning patients. And so when we walked into the room to start this on two patients, you'd have the two patients in the room, and then you'd have this each on their own ventilator. Then you'd have a third ventilator that was already set to the same vent settings and was inflating test lungs. You could visualize that everything was working properly before transitioning patients. So in terms of the first series that we did, so we had a total of 6 patients, 3 pairs. I want to just highlight a few things here. So one is that the patient pairs didn't necessarily have the same BMI. The second pair is a very good example where BMI of one patient is almost double the other. And similar for a predicted body weight. Additionally, the one thing we prioritized was matching patients on driving pressure, and you can see that we did that quite well here with the difference in driving pressure between each pair being no more than 2 centimeters of water. Tidal volume also was reasonably matched, but not explicitly so in the protocol. And you can see, for instance, this third pair, one patient was at 6.1 cc's per kilo, the other one was at 4.4 cc's per kilo as their baseline values. And then actually underneath where I highlighted, you can see these were legitimately sick ARDS patients with quite low P to F ratios. And while some of them had similar respiratory system compliance, they weren't necessarily matched in that either, because what we prioritized was driving pressure, was the thing that you were actually going to sit on a ventilator. So I want to briefly show a video here of 2 patients that got this video, lasts just about a minute or so. This video shows 2 patients with COVID-19 associated ARDS being supported simultaneously with 1 ventilator, a strategy termed ventilator sharing. The patients are spaced roughly 8 feet apart with the ventilator and freestanding respiratory monitors between them. The patient-specific monitor is placed adjacent to each patient's bed, making clear to whom the values belong. These monitors display patient-specific tidal volume, flow, and airway pressure and associated waveforms. The ventilator, positioned in the middle, is set to the pressure control mode to ensure mechanical changes in one patient do not affect the other. Ventilator displayed tidal volumes indicate the combined value. The circuit configuration includes a T-adapter and redundant antimicrobial filters on the inspiratory and expiratory limbs. All supplies used are medical grade and intended for respiratory clinical care in mechanically ventilated patients. All right, so that's what it looks like. So in terms of the data, so we recorded hourly, because we had those continuous monitors, we were able to record hourly ventilator characteristics between the patient pairs. And so this is the first pair, and I think one of the things that jumps out is that tidal volume is bouncing all over the place. And the reason that happened was because we were using pressure control as required by our protocol, and the HME filter was getting saturated quite rapidly. The reason that was occurring was because the first pair was the one pair that we did on an anesthesia machine. And we didn't fully anticipate how quickly the CO2 absorbent anesthesia in the anesthesia machine would get exhausted. But it was being changed every, I think maybe 3 or 4 times a day. And fluid was building up, liquid was building up in the ventilator circuit so quickly. So now the HME filter was failing, not only because you had exhaled moisture from the patient, but you had the CO2 absorbent converting CO2 to water, and then that water sitting on the other side of the filter. There were other important limitations, especially around alarm limits and sort of the physical configuration of the anesthesia machine. Collectively, which prompted us to never use an anesthesia machine again for the purposes of ventilator sharing. But you can see, even with those issues in the bouncing and tidal volume, patients were maintained within reasonably lung protective ranges, with tidal volumes between 4 and 7 cc's per kilo for both patients. So there were no adverse events, even though there was this issue with the HME filter. With the second pair, we learned our lesson and used an ICU ventilator. And so tidal volume was much more tightly controlled over time. You can see I highlight one example here where the HME filter saturated and had to be changed, but that was once during a 48-hour period. However, the other thing you'll note is that tidal volume in one of the patients, once we started ventilator sharing, jumped up substantially. And that was something that we, I think, had written into the protocol, but hadn't fully appreciated how important it was to make sure that the patients are really compatible or fully matched after you initiate paralysis. So this was a case of a patient or 2 patients were matched well on their ventilator settings with pressure control. And one of the 2 patients, the blue patient, was very actively breathing, including forceful active exhalation. And so with that forceful active exhalation and profound desynchrony, the patient had lower tidal volumes. And then once you paralyze the patient and you take away the desynchrony, tidal volumes shot way up. And so our lesson here was to do a redundant safety check after the patient's paralyzed and everybody's matched on ventilator settings before proceeding, so that you avoid this sort of unanticipated jump in tidal volumes. The third pair, incorporating all those lessons, went exceptionally well. So you can see tidal volume was really quite steady throughout the protocol. There was one dip from HMEF filter saturation, but again, that's just the nature of using pressure control modes. As resistance increases when the filter is failing, tidal volume will drop. And so one of the values of having independent patient-specific alarms is you can more easily detect that subtle changes in tidal volume and respond accordingly. But otherwise, we felt that this third pair went exceptionally well, incorporating our lessons learned from the first 2. So with that, the hospital leadership and our group felt that we were potentially ready to launch on scale if it came to it. And so we developed a strategy for different clusters of ventilators for different purposes, depending on what was needed, considering these sort of portable or transport ventilators, conventional ICU ventilators, repurposed anesthesia machines, repurposed non-invasive ventilators, and sort of acknowledging the limitations of them and sort of our hospital-wide schema for how we would support patients if it came to this. This is all, again, available in our protocol. So I want to end by emphasizing that none of this should have been necessary. This should not have happened in the U.S. And I think it's very disheartening that it did. I think the reason for that is that the premise that there were not enough intensivists or not enough ventilators to care for these surges was just simply wrong. It was simply not true. We're a very big country with a geographically dispersed population, such that infections will probably pop up in different parts of the country at different times. It's very unlikely that every major population center in the country would simultaneously experience such a rapid surge as we saw over a period of 3 weeks here in New York. And so basically what that means is that these acute staffing and equipment shortages are the direct result of fragmentation within our country. It's not that the US doesn't have enough ventilators, it's that New York City did not have enough ventilators, and our profession or our public servants or whatever it was who would be responsible did not respond accordingly to shift resources to where they were really needed in rapid enough time. And we were lucky that they just barely did, but it got to the point where these were the types of strategies that we were considering. And so this is really, I think it's very easy to say the federal government needs to do more, but the federal government is in charge of all these individual hospitals, right? Hospital leadership are also hoarding, they were hoarding PPE. Everybody was wanting to hold on to ventilators in case the outbreak came there weeks or months down the road. And it's completely understandable, but it really sort of left New York on an island during the first wave of this pandemic here. And so what I think really needs to happen is that we need one healthcare system, which we simply don't have. There needs to be coordinated movement of patients to areas of resources, moving resources to areas of need, and moving healthcare workers to areas of need. And that sort of mobility sort of happened in fits and starts during the surge in New York, but not in the serious way that would really need to happen if this came back again. There needs to be interstate collaboration, which I think professional societies and hospitals can own as well, not just government officials. And to some extent, New York State took a positive first step on that. So they tried to break down some of the hospital system barriers where, my hospital system might not work with another hospital system in the same city. We wouldn't want to share our data because we're all trying to one up the other. And that's sort of the capitalist culture of hospitals normally. But New York State stepped in and they mandated that hospitals start reporting daily bed availability and daily ventilator availability to the state so they could potentially reallocate resources if it came to that. So it's a good first step, but I think not enough. So in conclusion, COVID-19, I think really put our city's healthcare system on the brink of collapse. We're very lucky that it didn't get worse. Ventilator shortages can arise very quickly during the epidemic. So you saw within the span of 2.5 weeks, every ICU bed in our 9 hospital system was occupied with an intubated ARDS COVID patient. And another 2 or 3 weeks after that, we had more than doubled our normal limit of ICU patients. So it happens very quickly. And then lastly, I think ventilator sharing, it's definitely not a panacea. And the way we envisioned it was that it would be a stopgap to buy time for relocating resources. So if it got to the point where New York City hospitals were doing this on scale, we hoped that there would be enough public outcry that other parts of the country that had available ventilators or available anesthesia machines or what have you would shift them to New York so that this would be a stopgap and not a long-term solution. But I think it could potentially be done if pre-planned with well-matched patients in the right centers. And lastly, I think across our profession and across our hospital systems, more coordination would definitely save lives. Thank you.
That was incredible. Thank you so much for that talk. I think everyone is just kind of humbled and wowed by your sharing of that experience with us and walking through. Overall, tonight's session was just very well received, and I've just been getting a ton of all the feedback is just, this is awesome, this is incredible. So due to time, we will say goodnight to everyone. Thank you so much to each of our speakers. This was really an incredible night, extremely informative, educational, and powerful. So thank you guys. Thank you again to Dr. Leong, Dr. Lapinel, Dr. Kroniski, Dr. Amos, and Dr. Beitler. Thank you guys so much. Everyone stay well. Thank you so much for joining us tonight, okay?